Good evening, I'm Laura Ponce, I'm the chairman of the Board of Health, and we're bringing this meeting to order. First item, we need a motion to adopt the agenda. Have a motion?
So moved.
I second. Oh, I move to adopt the agenda.
Second.
Moved and seconded. Next, we're gonna move to board member, I'm sorry. I did that. Oh, I'm sorry. I have to have everybody vote. I apologize. I was going on. We'll go down the list. Are we going down the list or?
Well, since then.
Okay. Well, all in favor here, say aye.
Aye.
Okay, and then online I have Asha Rodriguez. Are you there, Asha? Dan?
Aye.
Anybody else on there? Ryan? Is that a quorum? Oh.
Ben. Let's go ahead and install Dr. Buckwell and then go back and vote for the
And we'll
approval
vote.
of the agenda.
Okay, so next we move to the installment of our newest board member, Dr. Chip Buckwell.
Okay, I will now administer the oath. Repeat after me.
Yes, ma'am.
I, Darren Chip Buckwell,
I, Darren Chip Buckwell,
do solemnly swear
do solemnly swear
or affirm
or affirm
that I will support and maintain
that I will support and maintain
the Constitution and laws
the Constitution and laws
of the United States
of the United States
and the Constitution and laws
and the Constitution and laws
of North Carolina,
of North Carolina,
not inconsistent therewith,
not inconsistent therewith,
and that will faithfully discharge my duties
and will faithfully discharge my duties
as a member of the Cabarrus County Health Authority Board of Commissioners.
as,
That's the part.
break that
Right.
down.
As a member of
As a member of
the Cabarrus County
the Cabarrus County
Health Authority Board
Health Authority Board
of Commissioners.
of Commissioners.
So help me God.
So help me God. Thank you.
Thank you. Now I will take the votes for the adoption of the agenda. All in favor? Here, aye. And Dan, I already have your aye. Asha, are you there yet? Okay. Next item is the approval of the minutes. We have these on the screen. Hopefully you've had time to read over these.
Aaron, can you close that box?
Asha's gonna log back in. You have to let her back in because she said she wasn't hearing anything either.
Got it. I'm in.
There we go.
Very good.
Ta-da.
Do you need a motion?
Yeah, and so, can we get a motion to adopt the minutes?
So moved.
I second.
Cecilia, second. All in favor here?
Aye.
Dan?
Aye.
Aye.
Asha. I got Dan and Asha as an aye. So moved. Okay. Now we'll move on to informal public comments. Ryan, do we have anybody?
I don't believe any questions were submitted ahead of time.
Okay, so we will move on to reports, and Sue Yates is going to present our financial summary.
So the first report is the financial summary. This report is as of the end of April. The revenues are projected to exceed the expenses at this point in the year. We are waiting on the Medicaid cost settlement to come from the state. We've submitted our report. We anticipate that to actually be closer to 3 million versus 1 million, which is what we had budgeted. And we received a notification today that it should be there pretty soon. So I look for that number to go up once we have that confirmation report from the state. Are there any questions about the financial summary report? I have two more for you, so we can go through those as well. The next report is just a snapshot of each of our departments, how they're tracking revenues to expenses. This year, we received a lot of funding sources that can roll over to the next year. So some of those funding is there available, but we'll be doing revisions to roll that over to next year. Clinical services is still light green because Medicaid transformation on the billing side, we are still working through quite a few issues with the PHPs and Medicaid for under that.
That has been a statewide problem that all of the health directors are bringing up, that before Medicaid transformation, most of us would get 95% of our bills paid first pass. Now, we're barely over 50%. That's, and so the revenues are really down for health departments across the whole state as transformation is taking some kinks to work out a little bit.
Yes. So, and then the variance report compares how we're doing this April compared to last April. We have a lot more funding sources, grants, initiatives in, so our revenues and expenses are higher this fiscal year over last fiscal year. Does the board have any questions about the financial report? I'll be back.
And now we have the Healthy Living Scorecard.
Well, good evening. Just as a refresher, we're just going to go over the scorecard presented for MDPP, which stands for our Minority Diabetes Prevention Program. But as our population result, we really want to see our residents living free of chronic disease, and we'll go through some of those performance accountability measures as well. Next slide. So the first population accountability metric I wanted to share was just our percentage of adults with diabetes. So we know that diabetes is the 7th leading cause of death in both North Carolina and the United States. And what we see here is that we have had a slight decrease of those adults that are 20 years and older with the diabetes diagnoses. But it's important to note that we're just slightly below the national state average of 10.1%. So we have a lot of improvement to still go along that way. When we look at our BMI results, since we know that is a risk factor of diabetes, we did have a slight decrease in 2021, but it's important to note that even though if we continue down this positive wave of decreasing BMI, we're still higher than nearby countings, including Union and Iredell. So it's great that we're in this regional project so we can collectively as a region decrease values there.
Is there, do you have any sense of why we would be trailing behind Union and Iredell? That surprises me in a way.
I don't quite know exactly why. It could be that we've had an increase of folks over the last couple of years to Cabarrus, and so we have new people coming from all over. But I think in regards to differences, it's not large differences that we see between Union and Iredell, but it's just important to note that even if we see a decline, we still need to focus on improving our records there.
I may ask a question. I know you probably got this data probably buried in here. Do we have it broken down by zip code? So we have an idea where the numbers are lying.
So our epidemiologists can definitely pull that data for us in Cabarrus. But one thing that we haven't done is do zip codes, particularly since this program is a regional effort. So that's part of the reasons for me mentioning Iredell and Union, because they would be regions that are underneath our jurisdiction. So it won't be presented in this presentation.
Thank you.
One other question to you, Bonnie. Is BMI the best indicator of potential for diabetes, or
It's the biggest
it
predictor.
is, it's the best?
That is overwhelmingly the biggest predictor, followed relatively closely by physical activity. Being physically inactive and being overweight are your two biggest risks.
I love all the questions. So when we talk about the importance of body weight when it comes to it being a risk factor for diabetes, it's important to note that the CDC is looking at this. So until 2021, one of our designations, so we are CDC, recognizes that our participants needed to lose 5% of their weight over the course of the year. So they do meet for 26 weeks. And what we found is that there was a slight decrease, as you can see. Part of that has to do with enrollment of those in the classes, but also for the designation. So in prior years, we were able to use an average value. Now they're wanting us to really look at making sure 60% of our participants achieve one of these three things. So either you're losing 5% of your weight loss, maybe you've lost 4%, and you're also reaching that 150 minutes of physical activity. And then the new one is really looking at the reduction of those A1C levels. So you no longer can really mask success or lack of success, I should say, by an average score, because you're looking at everyone individually with this particular credential. And then I just included the data that we have on A1Cs, particularly for those who have had lower values. And this is important because this is a service that we're able to provide with our partnership with LabCorp. So we have a partnership with them that anyone interested in the test can be sent over at no cost. So even if they're not eligible for the program, we feel that it's a great service for people to know what their metrics are in regards to the A1C. And you'd be surprised, many people don't even know what it is and have never really asked their doctor as to what those metrics mean if they are seeing a physician.
Do all your participants get their hemoglobin A1C?
Yes, so everyone does. The only exception for that would be if a person within the last year has gone to a doctor to get the test and they're able to use that result for us. But we do make sure we get everyone's A1C. And now because of this new criteria, we're looking at the end of the program. So our hope is not only are there being, not only are the participants more active, eating healthier, but they really do see a biometric change in that A1C level. All right, so in regards to habits, because we know healthy habits lead to healthy people, we have some data here just on the number of individuals that have increased their intake of vegetables. And I specifically picked vegetables because we know it doesn't have the sugar intake there. For the values in 2020, we had a limited number of people in classes, but I'm excited to say that we are almost busting out of the seams based on a new partnership with our Mecklenburg Health Department. But that is going to be something consistently measured for all of our participants. And this is a year change. So over a course of a year, we have at least 63% of people eating at least 2 cups of vegetables. And then the final one, the final one is really looking at participants participating at least 30 minutes of physical activity. And this is 5 days a week. So anyone reaching that goal. And right now, our most recent value is 81%, which is awesome, because if 81% of pairs were reaching that, we would definitely have a healthier population. Sure. So I say that to say that the program does work, not only in regards to the biometric changes that we see, but because the participants are making the lifestyle change necessary to maintain this over time. So this is our current effort to reduce the rates of diabetes in Cabarrus, and fortunately in our Region 4 area. Any questions before we move on to the wonderful world of WIC? Okay. So as a reminder, this is what our scorecard looks like. We're really wanting all of our children to be healthy, and then making sure that our pregnant women in the county are able to have a healthy pregnancy and delivery. And we've included some of those performance accountability metrics for you as well. Next slide. So here we're specifically looking at the BMI values of those from 2 to 4. And you can see we had a slight increase in the last years. It's important to note that over the course of the pandemic, we weren't able to see our patients and participants in-house. So the values collected over 2020 to 2022 will be errored based on that not having inpatient assessment of that, and that being self-reported by the parents and mothers. When we look at those enrolled, currently receiving prenatal services through WIC, we do see that there was a slight decrease in values in 2019. And so that's something that we really want to keep an eye on. We understand the relationship with our Medicaid services is so important to ensuring that a healthy population for our women, infants, and children. So it's important to note that as we see this decrease, there are big changes that have occurred. The first one is the co-location of WIC in the Dream Center. So that happened in 2019. Seems crazy because the years have just passed by because of COVID. Also, at the beginning of 2020, we were able to hire dual CHA DSS personnel. And so they are able to wear both hats in that Concord location. But again, this just brings to a greater awareness the need for increased engagement of our Medicaid enrollment specialists and medical partners, which we believe by us being in one space that facilitates the opportunity to have better collaboration and partnership ongoing. Next slide. So I know a lot of the discussions have been around the importance of disaggregated data. What is that? Why do we take the time to do it? And I wanted to highlight this specifically because this is the reason for why. So when we look at the low birth rates in our county, you can see that blue line. That's really our average across all of our races and ethnicities. But what you find is when you disaggregate the data, that large, the higher line that is that orange color, those are the rates for our African American babies. And so they're quite higher than everyone else. These are the things that you miss if you just look at that average across all of these particular demographics. And so this is an area that we're looking at and continuously wanting to do better at outreach, tailoring our approach to our African American mothers, but also making sure we're looking at others that are impacted, including our Hispanic babies and mothers there. So this is why disaggregated data is so important. And you can see that there's a difference of about 4% there.
To light blue versus green lines or what?
So if I'm looking at the slide correctly, the lighter blue line is your white low birth rate and the green line should be the Hispanic. Am I correct, Erin?
Yes, and then the blue, this navy blue would be if we were just looking at everyone in one bucket, but then disaggregated, you could see how some are higher, some are lower.
Yes.
It's interesting to me that, sorry.
Oh, no, I'm sorry.
It's interesting to me that the Hispanic rate is pretty low here too, because many communities that's the rate of low birth weight for Hispanic populations is nearly as high as African American.
Mm-hmm.
Next question, how are we sharing this information with other organizations who actually deal with these populations, healthcare organizations?
Yeah, so our performance management team has been great in helping us facilitate and demonstrate all of this information on our scorecard. So if you were to go to the WIC page, you could look at this data. And these are things that we can utilize in Cabarrus Wellness Coalition meetings, anytime our WIC department meets with other folks. So again, going back to your point, the importance of making sure that information is public as well as accessible.
But I think what you're getting at is how are we getting out there and engaging with the community and other agencies that could help us impact.
Correct.
We just had a conversation yesterday at a meeting where Atrium was also present. Infant mortality and low birth weight tend to be very married at the hip, so to speak. And we clearly are seeing that both are higher in the African American population, and starting to have conversations with them about how we might intervene and address this in a more effective way.
Because there are so many pockets like the free health clinic, the one Cabarrus Community Health Center, other areas where this commission will be valuable in their fingertips. And they, you know, they're not gonna come to the website. That's,
No, but the FQHCs are also required to monitor that as part of their grant from HRSA, and so.
we're hoping to do that.
What's that?
We're hoping to do that.
Yes, but I think, you know, we've been doing some turn the curve work here around some of these key metrics and starting to talk about how can we, CHA, engage more with our community entities to start having an impact.
I have a follow-up, by the way, to our conversation we had earlier, but contacting me, Don.
Oh, okay,
Looking at these.
okay.
If I may, those of you who are physicians, what leads to low birth rate? What action on the part of the mother over the course of a pregnancy leads to low birth rate?
Well, the biggest contributor is preterm birth. So what leads to preterm birth is there's a number of different factors, but young age, and then largely social determinants of health. You know, if you don't have access to good health care, to healthy foods, you know, that's why we have WIC. You know, the WIC is a national program that was started back in the, I don't know, 1950s or 60s, because you were seeing lots of low birth weight infants. So the WIC program is all about making sure pregnant moms, low-income pregnant moms, can get access to the healthiest foods possible to assure. Smoking, drug use can contribute to low birth weight. But largely it's that moms are unfortunately going into this. So a baby is full term if mom can get to 37 weeks, 37 to 40 weeks. Before 37 weeks is considered preterm. And so a number of different stressors, including the social determinants of health, really impact.
So I guess the follow-on question, given the differential between Black and Hispanic communities, both of which are frequently grouped in communities that are not as wealthy, not as available, of why the difference so substantially in the Black community?
Why is it so much higher in the African American population?
Since
In this county, why?
If
There's
it's-
such a difference in Hispanic.
I don't know yet, but being an epidemiologic geek, I would love to understand why. I would, and Cecilia, any input you have, we have noticed that it's the sub-ethnicity that can be
Yeah.
somewhat predictive. The Puerto Rican population has one of the highest rates of low birth weight amongst all Latinos. Mexicans have fairly comparable rates to the white population. So
I think that
what-
here in the county, the Hispanic community is very close
tight,
and tight.
yeah.
So they know where to find the information, they know where to go, you know, so everybody will know that, you know, they have to go to the Health Alliance or to McGill or, you know, resources. Churches for the Hispanic community are not so many, and there is a great support. Puerto Ricans, by the way, I mean, it's a different group of, you know, in between the Hispanic, you know, community. Number one, because they are considered Americans, in terms of, you know, your life. You are here as a Puerto Rican, you don't have issues like your, you know, legal status or all that. So it's kind of different. Language-wise, it's different. Most of Puerto Ricans are fluent in English. So, you know, that doesn't happen necessarily with the, you know, the Hispanic community. So there are a few differences too.
Yeah, I think the gap is so significant as to suggest to me that we need to better understand,
Yeah.
given that they are comparable communities in terms of economics and the social determinants of health.
I actually think Cecilia is really onto something with the closeness and the bonding. I read a study, it's quite a number of years ago now, but that showed that first generation Mexican immigrants to our country actually do pretty well with their not having a low birth weight. So they're much more likely to have a normal weight. And I think there's still very much a culture to the bonds and the closeness and that of, Mexican culture. Like the children of those first generation Mexicans who have grown up here and then have babies are much more likely to be at risk of low birth weight.
Yeah.
Because they've culturated to, unfortunately, the American standard, to discrimination, to those.
And it also happens that you will have a lot of families where you have like, teenage pregnancy. But I mean, sometimes that happens by surprise, but they have full support of the family. So the girl who is pregnant will still live with with the mother, and the mother will take her to, the doctor and support and all that. So probably with other groups, it doesn't.
I think when you look at the difference, you also cannot ignore the historical racism that's in American culture.
Yeah.
If you look at where some of our populations are, what access they have to food, to decent grocery stores, where they actually can afford to buy the best choices of meat, vegetables, and so on. Just the generational poverty for African Americans who don't own property or land, don't have that to pass on. There was a study was done looking at how African Americans actually take in their brothers and sisters, but don't have the funds to take care of grandmother because they don't have that natural resource, that wealth that they've built up over years. We're also looking at Hispanics, again, it's more of a newer population coming to America. So, even though there is racism, we can go back historically see racism towards Hispanics, but it's not been 200, 400 years.
Exactly.
So I think that we have to look at that as well, and where we're placing our communities and what access they have to a good, healthy.
Yeah, and I fully appreciate that as a not at all insignificant factor. Yeah, I guess I'm looking for the handle.
Sounds like Asha might want to offer up a second.
Yeah, Asha, go.
One thing I will say is a lot of these groups, just remember that after Hurricane Irma and Maria, you had some movement out of the Caribbean. And sometimes that first generation immigrant, and that's not the right term to use because Puerto Ricans and folks from the U.S. Virgin Islands are not, they're U.S. citizens. However, that movement and stabilizing themselves, the lack of resources and being able to do that, and then being hit with the pandemic on top of that too. So that, a lot of times that move starts with one or two people in the family, and then there's the ability to bring multiple family members together, which creates congregate living environment that only exacerbated things during the pandemic, but also put a significant burden on whoever is the primary breadwinner. And I don't mean that as a husband or wife, but I do mean that in terms of who has been supporting that extended family. So just something to think about when we talk about birth weight and the challenges associated with keeping that up. In addition to the transportation factors, the financial challenges, and then location as well.
As a person from the Caribbean, who did have to evacuate his mother from the Virgin Islands after the hurricane. I remember who was down there and saw the destruction. You brought up a very good point about the relocation of Puerto Ricans from the island. You have to keep in mind that in Puerto Rico, even though it's American territory, it's also a high poverty area, just like the Virgin Islands. That's right. So you have people relocating, already will have behind the social determinant health already, what it is coming to America.
I guess the reason that I'm focused on it and concerned about it is that, I don't want to overstate this, but if we have a community that is bringing children into the world behind the 8 ball at the outset, and then living in communities that have issues with social determinants, you're really poor little innocent thing is really not being served well. I don't know. I just, it touches my heart to think about that.
Yeah, and it's definitely an area that WIC and all of our healthy living programs will continue to look at alongside our partners, because at this particular point, it's seeing the data, right? If we had only looked at those averages, we wouldn't have seen that. So again, wanting to push the importance of disaggregated data so we can begin figuring out the whys and then those solutions collectively alongside the community that's most impacted.
One additional question that I think I know the answer to, but disaggregating the data along racial lines is very helpful because it identifies an area where we should spend more time and concern. Are there additional layers below racial that could be valuable in helping us to better understand the differences in the communities? So I don't know what data is collected as part of a birth process at the hospital or where a child is delivered, but I would love to take a deeper dive into the demographics to better understand.
Yeah, we can look at things like age and marital status and, you know, a number of it. They also collect information around tobacco and alcohol use, but those are not as reliable. This data comes from birth certificate data. And some of the fields are more reliable than some of the others, but geographic location, you know, can find pockets where usually those are associated with poverty and that.
Awesome. And Erin, I'm going to, if you don't mind, go back 2 slides just so I can clarify a point. So this slide, I just want to bring to everyone's attention that this particular one, I misspoke. The 2 to 4 years here is actually all of Cabarrus County. So you're looking at that 18%. And then if you'll slide back to our slide, these are our specific WIC data. So as we're going through the slides, I realize that's a big difference I wanted you to note. So even though there was a slight increase, if you'll go to the next slide. Yeah. No worries. I appreciate you. Even though there was a slight increase in weight there in BMI for those 2 to 4 over Cabarrus, when we look at our WIC population, it was relatively consistent. And there was a slight decrease in 2018. But again, that's what we're talking about in regards to some of that data being errored due to current waivers. And then the other one that I wanted, the other performance accountability metric I wanted to bring about your attention is breastfeeding at 6 months and the importance of that. And so we did see a decline in fiscal year 2021, particularly with formula shortages and just the importance of breastfeeding in regards to the development of the child. This is something we're really focusing on. And so it's important to note that we did have an expansion of our breastfeeding peer support counselor program in 2019. That grant is coming to a close, but we were able to continue the full-time employment status of our bilingual peer support counselor. And then it's important to also recognize when we have misinformation about the safety of breastfeeding, particularly during the time of COVID, that didn't help our values. So people were confused. So again, it's important for all of us to be sharing accurate information so we don't discourage people from breastfeeding, which we know is a very healthy habit. So as I close, I was told I need
to ask you a question? I'm sorry. You opened that door, but you opened the door of the formula. Do we sample formula here? Or what are we telling mothers about from WIC about getting formula now that there's such a shortage?
Yes, so actually just in the last couple of days, Marcel and Dr. Cole, feel free to chime in. Our marketing department, communications department has worked with our director of WIC to formalize some messages to go out to the public. And we're also making sure we're educating our staff on what's being done nationally to address this issue. So the great thing is from the state, they're sending us stuff basically every day to better inform our folks. But breastfeeding, if that is an option for you, definitely promoting that as an affordable alternative.
Yeah, the state just sent out today some guidance and updates and education that we can all share. And so that's what Marcel is working to get some of that posted out to folks to give them tips. But, you know, this is problematic because it was one major formula maker. And so the federal government is trying to work with the other 3 or 4 major producers of formula to increase the supplies, but it's gonna be a little.
Didn't they make a deal with that one company to start production again in about a couple of weeks?
They're supposed to get back, they're supposed to kick back up, but
It'll be a while before it's.
yeah.
But we do not have samples. So
No.
some food pantries may have donations that some moms just haven't used or whatever. But I know local pediatricians are helping mothers understand if you normally use Nutramigen, this would be a comparable for your child's needs for a special formula or things like that.
All of that's disappearing now. It's frightening.
Yeah.
So, and I mean, I know that some pediatricians are saying that after 6 months, you can use cow's milk or something. I mean, it's not ideal. So we just need to be
I
ahead.
think this gives us a push for as women are delivering right now, if you want to breastfeed.
Yes, thank you, Dr. Carl and Aaron. So as we move on in our next steps, one of the biggest things that we're looking at, returning back to our traditional community health outreach efforts. We have been behind a screen for way too long, and so we look forward to getting back out into the community at even greater rates than we were beforehand. We do want to continue those virtual services and program delivery, as we recognize that it did address some of the barriers for some of our participants. So we hope to continue that alongside in-person services. We'll continue to disaggregate data to look beyond just race and ethnicity as areas to do that, so we can dive deep into the metrics and figure out how we can be metric-led in the efforts that we continue to onboard. And lastly, based on the, it was a comment earlier about the importance of partnerships. That is a goal for us to establish new partnerships to re-engage existing relationships so that we can begin to address the areas of importance, not just for these 2 programs, but the others in healthy living as well. So as I close, I'll leave with a few asks. I have some amazing people in the room, so I have to ask for your assistance. And the main thing is just we ask that you assist us in improving these community clinical linkages. If there's a partner or some organization that you have access to that you don't see us engaging, please connect us. And then we ask that you also utilize your networks to increase awareness of the importance of diabetes prevention and the importance of breastfeeding and healthy weight, just so we can begin improving the referrals to these programs. And again, MDPP is a regional effort, and WIC is our county resource. And with that, I'll open with any final questions. I appreciate your time.
Before questions, I would like to share with the board that Alicia recently graduated, and she is now Dr. Alicia McDaniel. So, yeah.
Thanks, Erin.
Very, very proud of her.
Okay. Thank you very much, Dr. McDaniel.
Thank you.
Thank you for your hard work. Now we'll move on to the school health report with Tammy Alexander.
Good evening, and thank you for allowing me to speak tonight. So we are going to look at kind of where we have been, where we are right now, and where we're headed in school health. I think it's important when we talk about data to recognize that school health has collected data for many years, but that data has been driven by what the state requires us to report. So there's some limitations to that. So when we started looking at our scorecard and trying to disaggregate data, we were very quick to realize that we don't have the ability to truly disaggregate our data. We have some data subsets, we can't truly disaggregate it. So this was our best attempt at disaggregation of the data that we have. And this is looking at immunization compliance, comparing Title I to non-Title I schools. Probably would have expected to see some differences in immunization compliance, but this is showing that we have 100% immunization compliance at those schools. So the other problem that we have with our data is that this data comes after the 30th day of schools, when nurses have done all of that work and really gotten, most of those students to where they need to be for immunization compliance. So this helps us as a school health admin to recognize that we need to start thinking more strategically about the data that we're collecting so that our data holds some real value. So what does it look like on the first day of school when these students enter at these Title I versus non-Title I schools? Are there differences there? And then how can we collect data that will break down further? Are there differences between race and ethnicity? Are there differences between different subsets within our community? So different zip codes or just different schools. Those are things that we recognize that we need to start collecting. Vision screening is something that is very important at an early age because we can catch things that will impact learning. What we can see from this data is that there was a huge drop in the number of students who received vision screenings at school last year. We feel like that's a direct impact of COVID. Volunteers weren't allowed in the schools. Nurses weren't doing mass vision screenings. So we can see there was a significant drop in impact. What we did still have last year was fairly the same amount of students who received referrals and were able to secure care. So that's a positive finding. But this data, again, is very limited. So we've given you a percentage. Well, how many students were there? Did we have 1,000 students who were referred and secured care, or were there 33? You can't tell that. So I think one of the biggest things for us to take from school health data right now is that we have a long ways to go. If you would hit that next slide, please. So we are very excited about the EMR, which was approved in the budget this past year, and we have started that rollout process. It's called SNAP. We feel like it's going to allow us to pull some data that we can break down to a much more granular level, but it's also going to allow us to develop platforms to pull the types of data that we want. So we're not going to be just limited to the state report. We can truly start to say, what data do we need as a school health department to make departmental decisions and to truly impact the health of our schools and our community. In school health, we know that we need to focus on recovery and resiliency. We have to look at how to retain staff. We want to focus on team building and development of true public health nurses. So a movement away from nurses who identify themselves as school nurses and truly identify themselves as public health nurses who just happen to work in a school setting. So really starting to create some image or some branding for our department. And then like Alicia's department, we also want to work on that building and strengthening of partnerships. So we're blessed to have very strong partnerships with both school districts. But what can we do to strengthen those partnerships, to go beyond what work we've done in the past, to expand the work that our school health department does? And then how can we create stronger relationships even here within CHA, rather than working, in a silo, as often said, truly working collaboratively together to have partnerships that will have a greater impact.
So this is really interesting to me. Is there a category of public health nurses? Is that a certificate? Does it exist?
So there is a certification that you could get. There's a credentialing program that we're actually looking at right now. And it is a title. Our nurses are hired as public health nurses. But if you were to ask most of our nurses what they do, they would tell you that they're a school nurse. And that's true, but they are a public health nurse first and foremost. And it's something to be proud of, that we really want them to recognize and to understand that as a public health nurse, you have a large impact in the school.
And how many of our school nurses have that certification?
None of our school nurses currently have a public health certification. We have a large percentage that have a national certification in school nursing.
It seems to me that this is an important differentiator, both in terms of the education and skill sets, but also an opportunity for us to offer something more to our folks. Is this the kind of program that can be offered through community college?
The certification is just a testing process. It's actually a self-study and then a test at the end for the certification. The credential that Dr. Coyle and I have talked about, it is also, there's a set of CEUs that you have to complete. And then at the end of that, you get what's called public health nurse ready credentialing.
Seems to me that we ought to have the conversation with some of our educational partners about this.
We have been talking about it. We would like to start to have the nurses do this, but as Tammy said, it's really a self-study and modules that you can work through. Actually, I think it is probably UNC that developed the modules.
It's actually through another university, and I'm not going to be able to tell you now. I feel like it's in New York, but it is supported through our public health nurse association in North Carolina. Thank you.
Real quick. Two names. First of all, I think the 100% is a really good indicator of the work that the school nurses and the schools do together to make this work. So thankful for the school nurses, because I promise you the schools couldn't do it on their own. So the school nurse piece of that is hyper important. I think because of what we've gone through the last 2 years, another piece of data might be important to note is that who are now opting out of immunization, period. So I don't want to lose the opportunity that you're creating to not actually capture that also at some level and how that's going to impact
And I think it's an
schools
important,
and school health.
I think that's an important note that when we talk about vaccine compliance, that includes religious exemptions, medical exemptions, and people who are
And
up
that
to
be
date.
broken out. I was wondering that too. Can we get that back? So
Yes.
we know that they have complied by submitting a form, or they have complied by getting vaccines. Can we break those two apart so we can see what's actually happening?
Absolutely.
Is your electronic health record, is it gonna be at all schools, and are they all connected?
It will be in the Cabarrus County schools and Kannapolis City schools. When you say are they all connected, if a student were to transfer from one school to another, we can transfer that record so that the nurse at the other school would have access to it.
And it's transferable between counties, between school districts.
Oh.
Only if the district has record.
Right, well, the immunization information
Yeah.
is transferable
Yeah.
between districts.
Yes.
But I think I know where Dr. Pons is going. Can we link it up with like Epic? And
Well, my question was gonna be, can you, if you have a nurse out at one school, and they have a question around, a student and a nurse in another school, and look at the record at another school, so.
So one of the
Now,
nurse
those are looking-
supervisors,
Yeah, Kannapolis or.
one of the supervisors would be able to have access to that and see it. Yes. Thank you, Bob.
The other thing that I just mentioned is that I don't know that you can ever do enough to appreciate frontline work that's being done. And I think that within our political or municipal governments, we ought to look for opportunities. Certainly, I don't say meetings regularly. Nothing wrong with the city of Kannapolis having a nurse and school nurse recognition or a public health nurse recognition event, proclamation, just to enhance the thank you, if you will, public recognition of excellent work that's been done.
No, I would echo that. Everything we see, our school nurses go above, public health nurses go above and beyond just the average call of duty. I can talk and think about at Cabarrus elementary schools, the nurse there has done a magnificent job in not just doing what is in her by job description, but she goes even beyond that of taking care of kids and working with the gardens and doing so many things.
Yeah.
And they are a valuable part. In fact, they're a part of the school family, school
Yeah.
culture. So I think, definitely recognizing them for the All of
Yeah.
the district doing on a daily basis.
It's a challenging job because of the independent nature, sort of you're alone out at a school, or, you know. I'm on the rounds right now with the school nurse administrators to get to all of the schools and meet the nurses. And it's really heartwarming to see the camaraderie between the school nurses and the staff and how everyone's working together. And so taking those opportunities to acknowledge is really important.
I think the school nurses are amazing. I think nurses are amazing. School nurses are amazing. Like, I know all the guys because we're out at the arena, you know, during the pandemic. I met all the school nurses out in the arena backstage during the pandemic. So just being wherever you need it, wherever you are. And as a physician in the community, when I was taking care of patients in Mount Pleasant, I would often get called by the school nurse there. We all get calls like, this is what's going on. Can you look at this child? So the relationship between the medical groups and the school nurses in this community is also very well established, and it's an important partnership too, so.
And I would be more than happy to talk with the baseball team about a recognition night at the baseball games, if that would be something to do, but you've got a large community gathering.
Yeah.
Where they could be recognized.
Bonnie thought you wanted to go play baseball.
The ball is reach the plate.
That's right.
Watch it.
Oh, it's wrong-handed.
You're on full ice, girl.
Oh, yeah.
And now we're going to the COVID update.
Hey, before we go on, I do have a question. How well prepared do we think the school nurses are? Do they need additional training or help with adolescent mental health, which seems to be, you know, a increasing issue and lack of resources? There's more we can do there.
I feel like the level of expertise is really dependent upon the nurse themselves. So we have some nurses who have a mental health background who feel very comfortable in dealing with mental health issues. We have other nurses who come from a critical care background and their only work with mental health is, you know, what they had in nursing school. We have talked as a department about what training needs to be provided to our nurses as we recognize the increased need for a mental health response for students and for staff, quite frankly, in the school setting. Our nurses deal with mental health on a daily basis, and things that they're not comfortable with, they understand the process for referring, whether that's to a school counselor, school psychologist, social worker, or an outside referral when needed.
You good, Dr. Hagler?
Yeah, that sounds like an opportunity for training, but that's something we can, you know, we can talk. That just seems like that is going to early. I mean, first the problem is there aren't a lot of places to refer to, and we refer too late. Recognition and referral to what resources are there really important. I think it's going to be an increasing focus on the school. So training is good if everything.
Hey, Dr. Hagler, if I can also add in there, when we talk about the school nurses, they're also embedded somewhat into what we call the multi-tier system of support.
Mm-hmm.
So oftentimes we have a program where our psychiatrists, psychologists, social workers meet independently. And they also bring in the nurses, especially when they're dealing with certain students with the social emotional learning component. So they're finding themselves not just working alone, but they're actually working as part of a team in the MTSS process.
Okay, this is, I have a quick question. So I guess for students who are on the cognitive development disorder spectrum, how do those kids with either an IEP or others, how do you all loop in I know they manage medication administration for their students who have ADD or ADHD. But do you feel like they have enough understanding of the disorder itself, or at least the spectrum of disorders, to help redirect or to escalate the need for additional support for those students? And I say that only because what we are finding for ourselves is we tend to lump them all, these children, into the mental health bucket because of the symptoms they present. But it almost seems as if we can get further upstream in terms of being able to support them, then we can actually get them better help pretty early on in a diagnosis.
So I think, again, that the beauty of having the school nurses within school setting is that there is that team who, we have educators who their expertise is understanding the cognitive delays and to have the supports there for these students. So the school nurse is really playing a support role with those students and are able to meet the needs based upon what the educational team identifies.
Thank you.
And I'll go back again to the partnership that exists through the multi-tier system support process, where the school counselors, the social workers, psychologists, and the nurses work together. And really, it's very targeted. It's not a general conversation. They actually talk about individual students and the needs and how best to serve those students.
I think what might help, there's that MTSS flow chart.
Yeah.
If you could get that to Dr. Coyle and let her disseminate that to the board, that would be helpful in describing how that process works and how people get included and then not included in the next meeting because we rule things out. So it works.
You can get it too.
And
What's
the
that?
chart was called what?
Actually, a chart too.
No, I don't have access to
He's still delegating. So
You have access to stuff I don't have access to.
I'm calling time. Aaron?
Before we go on, I do want to recognize Kim Reagan. Kim graduated with her master's in public health. We are, I know, we're so elated. All right, well, it wouldn't be a board meeting without a COVID update, so here we go. So real quickly, we are seeing an uptick in cases. I'm sure you've seen it on the news, heard from friends and family. So we are seeing this uptick. If you'll remember, several months ago, the state said, case count is important to keep an eye on, but it's not a key indicator as we move into this phase of COVID. And so what I'm going to show you here in just a minute are some of the other things we're looking at. So you can see in red, I've highlighted for you, in about a month, the week of April 18th, we were at 62 new cases in 7 days, and now we're at 302. There were months ago where if we had only had 302, we would have been elated. So, it's all perspective when we're looking at these trends here as well. I also want to note, because I think it's important in terms of deaths, and I believe we sent this out to the board,
Yeah.
The state updated the death reporting based off of the new state electronic death certificate process, which Alicia Richards, who's our vital records registrar, manages. And so we did have a jump, so you'll see that 470 to 494. We did not have mass fatality that week. It was just a change in how they were reporting those, and it went back to January of 2022. So as you're hearing folks talk, please know that there was a change in reporting protocol.
What's missing here is hospitalizations.
It's on its own slide, it's so important. Okay, so just real quick, graphically, from the very beginning of the pandemic, you can see that slight tick up, but certainly nowhere where we have been with previous surges. So hospitalization. So we're really looking at hospitalizations in a regional, with a regional lens. We happen to be in the Metrolina Healthcare Preparedness Coalition. So all of the hospitals in the greater Charlotte region report up to the Metrolina data collection point. So you can see here, these are trends for this entire region. And again, you can start to see a little bit of uptick, but Asha and Dr. Hagler's teams do a great job communicating with us every Wednesday on how things are looking here at Atrium Health Cabarrus, what their capacity is, if they've reactivated their command center. And so right now, all is standing and no issues. But I am going to pause and let our folks who work there day in and day out add to that report if they want to. Asha and Dan, any additional information you want to add there?
I would just say we're pretty stable at this point. Thankfully, I really don't have much more to add. I will say that we've seen a little bit of an uptick in obviously in our employee exposure as well. But we are just continuing to manage through that.
Okay, very good. Just quickly, you can see here a really fascinating kind of evolving of the variant. So that light pink shade is the variant BA2, which is really the predominant strain of COVID at the moment. But what we're not seeing is any additional major impact in terms of severe disease or death over the BA2.121. I know. Okay, so the CDC community levels, the good news is that a majority of the nation is in green, which is the lowest tier. You can see here 2 counties in North Carolina are in that medium, but this is essentially helping individuals understand and assess their level of risk when they're going out in the public, going to plays and to shows and to movies and things like that. So good news to report.
Is that us in the darker blue and orange?
It is, it's just showing that.
That's what.
Yeah. But there's no difference in the shades of green. So Asha alluded to this. I want to talk to a little bit about what's going on here at CHA. So you'll see here our vaccine status. 58% of our staff are both fully, they're vaccinated with both of their initial doses and boosted. And so, but what you can see is that then we have the remaining part of our staff who are not. So 9% are partially vaccinated or unvaccinated. That orange piece of the pie there is 30% of staff are vaccinated, but they're overdue for a booster. And then the green are vaccinated, but they're not yet eligible, meaning that they just got their second dose within a time frame that doesn't make them eligible. Why is this important? Because we too are seeing an uptick in our employees. And so the blue bars here are individuals who have tested positive, meaning that they cannot come to work. But then what you'll see in the orange is these are employees who have been exposed and could not come to work because they were not also boosted. And so wanted to show that, and this only goes back to April 9th. And so you can see really the significant uptick we had, especially the week of May the 14th. So we are really working hard to educate staff on the importance of getting boosted, what being boosted means for you in terms of your safety, and then work impacts if you were exposed, and then talking about some internal protocol to make sure that we are not having to quarantine staff, thus having a negative impact on the people.
And just to point out, it's not that we've had a downturn the last week. We are in that week. So the numbers are not final for the very last bar you see there. They may or may not continue that.
Thank you. Yeah, Lynn is tracking this by week ending. So this is week ending May 21st. So that's the week end right now.
Is there anything that the board can do to support your efforts internally?
Well, I think, one of the things that we've been discussing is right now, the requirement here for CHA is that you are fully vaccinated, which means you've completed the primary series. We do not have a requirement that people boost. So because we have a requirement that people are fully vaccinated, we have 90% of our employees are fully vaccinated. Only 58% are boosted. So I think as we watch, if this continues and we continue to have this organizational impact, and we sort of identified that once we get above 10 people isolated or quarantined, it starts to impact our efficiency of operations. So if that continues for a few weeks, perhaps we would be considering whether or not we need to make boosters also a requirement for staff. But we're hoping by going out with some voluntary education of, please understand, if you are not boosted, you now get health, CDC healthcare guidelines say you need to not come to work days. And
I
so,
assume there's good data at this point that says if you're properly boosted, if you do get COVID, you're not going to be quite as sick, you're not going to be hospitalized, you're not going to die. Is there statistical data that?
well, even being fully vaccinated seems to be offering protection. I think that's why you see the cases going up, but as you saw with hospitalizations, they're staying pretty low. Most people, the fact that people have either natural immunity from, the estimates are that up to 45% of Americans got infected by Omicron. So between natural immunity and then vaccine immunity, a lot of people are having at least partial protection when infected and not getting as sick.
And so just really quickly, wanted to share with you, we kicked off our Cabarrus County Community Recovery and Resiliency Coalition last Thursday. I walked away full of hope and energized after this group. So we decided, well, we really went in as a group that over the next 7 months, we'll be providing and asking this group for feedback and input on how COVID has impacted the county. This is not about feedback for CHA on how we performed. We are one spoke in the wheel. This is about really how Cabarrus County fared through this. We'll strategize together on recommendations for moving forward to recover and be more prepared before the next emergency. We'll strategize on recommendations for supporting resiliency efforts, whether that be for youth or teachers, healthcare workers, really all our community members. Provide suggestions on the use of additional funding resources that may come to Cabarrus County. Strategize on recommendations for moving forward, and then provide feedback and input to local leaders on how to support the community. So we really, we have a great cross-cutting group of individuals. So I didn't want to list them by name here, but we purposefully wanted, again, a broad cross-section. So we've got childcare professionals, an elected official, 2 faith leaders, 3 general community members. So you can see here, it is community heavy, and we turned CHA staff away who wanted to participate because we did not want it to be CHA heavy. And so our next meeting will be June 9th in the community rooms downstairs. You are more than welcome to come. This is a very data-driven and data-intrigued group, which was exciting. We set some, not really ground rules, but just expectations, and man, we really put those to good work. That first meeting had some really robust conversation, and so I think this group is going to, really bring to light, like, hey, before the next thing happens, we got to make sure we have A, B, and C in place, and when the next thing happens, we got to make sure that these groups are the groups that we attend to and make sure are taken care of first, or at least we have eyes on them. And so we're really going to learn a lot through this, and I'm really proud of the team that's put this together.
This is being driven by CHA, even though it's abroad.
Yes. Yeah. So the state has put out some recovery language and things that they're doing, but we're not really aware of any other local organizations statewide that's kind of driving some coalition work. So we really felt like it was time, number one, because we feel like we need to start offering some hope. And we also just need to start preparing. Because we hope it's going to be a really long time before we need to put some of these things to use. We also want to identify gaps that we haven't identified, and I walked away learning the other 9 things that I had not considered. So it was great value.
I assume if there's not a number, that it's just one.
Yes. So you're always welcome to attend, but it'll be once a month for about 7 months. So we've got quite the commitment from these individuals. Any questions about COVID or the recovery and resilience?
I do want to point out that, and I already shared with all of you that Erin was selected as the winner of the Reynolds Award, which is this award for the person who had the biggest impact on public health in the past year. That's huge. And it's largely because of the work she did leading
It's a community effort, and just to put one name on it, so for the community.
For the health director's report, in the interest of time, since we are more than an hour into the meeting, I'm going to say it's in your packet. Please read it, because we have been busy doing amazing things for the past month or two. And if you have any comments or questions, please let me know.
You make us read.
Absolutely.
Okay, thank you. So that brings us to the consent agenda. And we need a motion to move into consent agenda or not, till I forget it.
She'll review it and then we'll do the motion.
So we will have quite a few budget revisions in May and June for the board. The majority of the revisions for May have to do with the rollover funds. So identifying which funds that we are not using this year that we will be rolling over, budgeting for and extending our efforts into next year. Does the board have any questions about any of the budget revisions at this time?
We also have to, you'll see the first two items are fairly large sums. Our dental community mobile program did get up and running, but it had a limited year this year because of COVID. And so we had to estimate we had overestimated revenues, assuming we'd be out there all year providing services. So those have been, we had to adjust them now that we're at the end of the year and that program is finishing up.
Thank you for that addition.
Okay, now, I was reading. So, can I get a motion to accept the budget revisions?
So moved.
And can I get a second?
Second.
All in favor in the room? Any opposed? Asha,
Aye.
Dan Hagler,
Aye.
so after. Next, we're moving on to the business agenda.
I'm sorry, I couldn't see who, the owl didn't move to who motioned it. Second.
What was it?
Something about the owl not moving? Can you hear us?
I can hear you, but I couldn't, it wasn't catching up with who was talking, so who motioned and who second?
Who made the primary motion?
Okay. Mark Spitzer made the primary motion and Steve Morris seconded.
Thank you.
Okay, and then now we move on to finance policies.
Yes, we have 3 policies. I believe Dr. Still is on the call in case any questions about the 2 dental policies. We took feedback from Dr. Daler and revised those policies accordingly. And then we have the travel policy and there were no changes in the travel policies.
So can we get a motion to accept the finance policies?
So move.
That was Chip Buckwell, moved. I made the motion, second.
Second.
Darryl Adams seconded. All in favor? And then Asha,
Aye.
Dan Hagler.
Aye.
So the motion passes, thank you. And then,
The board governing documents, we are required to have our board review our bylaws, our corporate resolution and our operating procedures policies each year. For our bylaws, these are all in your packet. Hopefully you had a chance to take a quick look at them. For the bylaws, we have put a change in there. For our physicians and dentist positions, we included the phrase it had originally said must be currently a practicing physician or dentist. We have expanded that to say must be current or previously a practicing physician or dentist in the county. This allows us to have someone who may have retired but has been an active participant in the county to serve on the board. This will apply to Kim and her reappointment, Dr. Daler's reappointment, which is the next item on the agenda. She is excited and willing to continue to serve a second term, but she is in the process of selling her practice and is not sure if she's going to immediately start up again. And so it allows us to keep her on the board with her incredible wealth of public health experience, even though she may or may not choose to. We need a motion to accept that.
I make a motion to accept the change then.
Motion by Ms. Twist, second by Steve Morris, all in favor? Osh Rodriguez,
Aye.
Dan Hagler,
Aye.
motion passes.
For the corporate resolution and operating procedures, we would just be looking for a general approval, again, so that we stay on our yearly update. I do need to point out that I've made a mistake. I reviewed this all last week. I was reviewing it again right before the meeting, and our operating procedures actually state we will meet monthly on the second Tuesday. So I do need to correct that and bring that back next month. So what we'd be looking, I apologize for that oversight that I didn't catch that before, right before the meeting started. So we'd be looking to reauthorize the corporate resolutions, and then with that one change in the operating procedures, approve them.
So I need a motion to, for the corporate resolution, and then we'll bring the operating procedures back next time. So,
moved.
Darrell Adams moved, second by Mark Spitzer, all in favor?
Aye.
Osh Rodriguez, Dan
Aye.
Hagler.
Aye.
Okay, thank you. That passes. Now we move on to, the preliminary budget. Just Sue again.
I'm gonna
And
start out, and then
I'm
Sue's gonna
sorry.
be available to, here, you start. I'm moving up here more not for formality, but because I won't be able to read it. I don't know about the rest of you, but I was struggling with those scorecards. So, we talked with our finance committee the other day, and they made some recommendations about giving a sort of general and very high level overview to help you all understand the budget more effectively. As you may have noticed, it does go on and on and on for many pages because of all the programs that we have. That's a great indication of the good work we do, but it can also be a little overwhelming. So, at the beginning of FY '22, our preliminary budget was at almost 25 million. To start FY '23, you were looking at a budget before you of 35.9 or almost 36 million. Now, next, you can click. You might say, wow, $11 million added to the budget in 1 year. No, because again, as we are required to have a balanced budget, so we get a grant, then we have to come to you with all those budget revisions we keep bringing to you with. And so because of what you'll see is by right now, in May of '22, our budget is now at 31 million already. So since the beginning of '22, we've gone up by $7 million in funding. A lot of that coming, as you can see, from COVID, 3.15 million, because of all the additional dollars that we have been given from the state and feds and assistance from the county to address the COVID pandemic. This ARPA Regional Workforce Fund is a grant from the CDC to the state and then to the regions that's wrapped up in the COVID funding, but it is also expanding and helping health departments work in a regional capacity to
be prepared for any pandemic. So, COVID identified for us where we have strengths and where we have weaknesses. And these grants are to say the health departments, now you know where some of your weak areas are, here's funding, and that will help you improve your efforts so we can prevent any additional pandemic issues. And these next several, you will notice, are some of our priority areas. These are the things that I talked to you last August about and the year before and said, this is what we are focused on. Our county data tells us we need to focus on equity, like you just saw, low birth weight being much higher in African Americans in Warren County, those kinds of things. We need to focus on equity, we need to focus on social determinants and behavioral health. So this shows throughout the year how we have obtained additional funding to support these programs. Equity, you might say, looks a little low. This is the money we got from the state for our coordinator position. But what we are doing is incorporating equity into every other program and grant we do. So a lot of these grants actually have equity dollars in them because we're putting an equity lens over everything and looking at our data and saying, how are we doing a better job? So we brought in an additional $1 million for community health workers to help with social determinants. And then we've been working on building behavioral health programs as that is identified as one of our county priorities. We were able to get funding from the county to begin counseling services down in Concord to help individuals who have really been impacted from the COVID pandemic. We also obtained funding to expand our medical assisted treatment program, which Attorney General Josh Stein was just here last Thursday because it has been identified as a best practice in the state for harm reduction strategies. And then the Elevate program is working with schools on trauma-informed training. So helping school nurses, teachers, all the staff be more informed about a trauma-informed approach to mental health issues for the children. We expanded our healthy living program, additionally $100,000 for grants and environmental health grants. It's the first year our environmental health team has gone after grants. And then school health is additional money we get from the schools for covering summer school and additional work hours for the nurses over and above the funding that we get from the county. So that shows you how we arrived then at the $31.5 million as of right now, and we'll be finishing. We'll have the final numbers for you then at the August meeting. So we really. What you'll notice is our budget has increased by a little more than $4 million now for next year. Right? So again, we're currently at 31 million. The budget before you is for 35.9, a little bit more than 4 million. Go ahead. And this again is going to show you where the increases are coming from. So just the salary increases, we are proposing a 3.25% across the board increase, which will increase costs by $268,000. We did talk about this for a bit of time at the finance meeting the other day because we have learned that some other counties are offering higher percentages. We decided the finance committee thought it'd be the best thing would be to continue with the 3.25% and reassess that maybe in December and see if we might need to adjust salaries at that point. And then we are adding 4 new environmental health positions. That may seem like quite a bit to you, but this county is growing. And we also have the problem with the sewage issue, and so we're getting a lot of on-site requests. We have an 8-week delay right now. If someone calls today and needs, to get an inspection for a septic system, it'll be 8 weeks so we can get out there. We've got to close that gap. So we're bringing on two additional on-site positions to close that gap, and then also two food and lodging staff, as there are more and more restaurants and more and more events that are requiring our staff to be out there. Those will remain in the budget if the county funds them. They have been preliminarily approved.
Yes,
But
they
we
are
will-
all in the preliminary county budget, which I expect to be no problem with that.
There's another additional 368,000 for school health. This is to hire an additional school nurse to cover. One of the new schools. These all, I'm gonna say, wow, well, that's quite the salary for one school nurse, right? But this is also an arrangement that was made a number of years ago, actually before I got here, where we have increased one of the hardest positions to recruit for here at CHA, as these three women can attest to, are school nurses, public health nurses, environmental health. And so in order to be more competitive at recruiting nurses, we've been over the years, we've been offering them better benefits and higher pay. And so each year, the county has been covering that increase. We've been sharing it with the county, and it was over the 4 years that it was gonna roll into where the county was covering that increase. So that's why you see that little bit of increase. And to address social determinants of health, we have put 2 additional positions into the budget this year: a dental patient navigator to get our predominantly children connected to the care that they need. We're thinking that's really going to improve their, one of our biggest, one of the metrics that we have that is problematic for us is getting access to care for people who need dental care. So we want to focus on that, and then also to have a clinic interpreter. Our stats show that a significant percentage of our clinic patients are limited English proficient as primary language and only in Spanish. And so we have been struggling to provide top-notch quality care with the one interpreter that we have. So we're adding another position for interpreter. And then this is the Cabarrus Youth Detention Center program. And this is DA is funding us. We provide part of the care there. We are expanding they have asked us to take on all the care there. Again, they think that the quality of the care that we are providing to the youth there is exceptional, and they've asked us to take on the additional youth in the additional section. And so that 400,000 is largely salaries. The regional ARPA workforce that I just told you about, which is expanding workforce capacity, will add $3 million to the budget for this year. We just learned a day or two ago, a couple days ago, that it will roll over. So some of that will probably get amended next year down, as we can push some of that money into the following year. We projected an additional $1 million over what we did last year for our Medicaid settlement, based on Medicaid settlement being higher than we've anticipated the past 2 years in a row. And then our dental suite down in Concord at the Dream Center is, the equipment is getting very dated. We've been there 10 years, and it has not been replaced and needs to. So we'll be doing a capital project there. So that's where most of the money's coming from, that adds that extra. And you'll notice that looks like more than $4 million, because some grants are rolling out or not getting the.
Does that include the opioid settlement monies? Is that?
Not yet. We haven't gotten that. The county has not gotten that check, and the estimates are that it might be as late fall before that first check comes.
And of course, that's going to be spread out over a number of years.
So we will come back once we know, and through planning, if we're going to get some of that money, then we'll be coming to you with a budget position at that time. That's the beauty of the way we do business here, that, it feels like the budget's always a moving target. as new funds come in and go away, and constantly coming to you with that lovely long list of budget provisions. That's. Next one. Just wanted to show you the revenue. So on that budget of 39.9, about 10 million is the county request. We get an additional 15 million coming from state and federal grants, an additional 6 million from billing, from Medicaid, but other insurers. Our Medicaid cost settlement is estimated at 2.9 million. Contributions, private grants, just slightly under $1 million. And then the others. I draw your attention to the fund balance of 0. We are feeling confident and that we will not need to use any fund balance to balance our budget for next year. All of our revenue is coming from this.
Yeah, I have gone to fund balance limit at 0. That's good. That's very good. Thank you all for doing that. Something into that.
And then if you pull up the last slide. So, I'm sorry, this. So again, just to show you in our priority areas, so we are focused on behavioral health, equity, social determinants, and healthy living. These are the additional dollars over FY22 that we have found additional grants to put in the budget. So wanting you to see that we are really focusing on going after the grants and identifying opportunities for additional revenue sources to support the areas we've identified as our priorities. And now for the last slide. So sort of one of the things that if you were, those of you who were on the board last year, you will recall that we were somewhat surprised by the additional cost settlement dollars that we got last year that put us with a substantial excess revenue that we put into fund balance. Same thing is happening this year. Up until 2 years ago, we were getting just a little over 1 million a year, 1.2, 1.3 million. The past 2 years, we've gotten over 2 million. This year, we will get over 3 million. It's projected. Didn't get it yet. It's coming. So we've been having conversations, and I've asked students to look into some of this. Like when we get these large, like when cost settlement is significantly more than maybe we were anticipating, we don't usually find out till late in the year, and then the check doesn't even come till sometimes the following year. And say, how can we make sure we are using that money in the absolute best way to advance the health of our county, rather than just popping it into fund balance? And so we kind of arrived at this and sort of like that. Any comments you have, but hopefully also then sort of non-approval of to take, we cannot set up separate funds. We can have one fund balance. The finance committee suggested we have sub-accounts so that we can take about 1/3 of that revenue and allocate it for capital projects. So if and when we might need to either do an extensive renovation somewhere or get extra building space or something, that we have the money to do so. We, unlike the county, can't issue bonds. So we can't get it. We can't have debt. So we can't take out a loan to buy a building or something like that, or do renovations. We have to figure out how to come up with the cash. So having a sub-account to allocate dollars towards capital would be one way to accomplish this. We would like to start investing some of the money right back in the community initiatives that are our priorities. So helping to fund community agencies who are partnering with us on both the opioid pandemic, on mental health, on social determinants of health. And then a third to fund balance, because hopefully you recall that as our annual budget increases, the amount we have in fund balance has to come up. And so we have to keep putting, keep the fund balance at the level that it needs to be. So that was the high level overview, kind of just, this is where that 35.9 is coming from. Sue's got all of the detail or any additional questions that you may have. And Sue, is there anything else that I missed that you might want to say?
Yeah, you did a great job. So after this, in your packet would be the detailed budget, a budget summary. Then there's going to be the fee schedules for environmental health, dental services, clinical services. And at the end, which really might interest some of you, there's summaries from all the different program areas. So if you have a particular interest in school health or a particular interest in what our IT department is doing, you can go in and read those program summaries to find more program level data. So that is included in your budget package as you browse it for your reading material before you fall asleep. If you have any questions, please shoot those my way. This is the preliminary budget. I already now have one change for the final budget. Some of the WIC funding has changed around, so I'll be working on that for a final budget for June. And it's the final one we will begin with.
That's a good question. Have you seen an increase in legal fees because of
Yes.
Determinants?
Yes, we have seen an increase in legal fees. They have
the what? What was the
Because of just the era of the temporary and the political climate.
Oh, yeah.
Yeah, there's a, public records request, personnel. Yeah, it's an increase in legal fees.
Thank you. Any questions?
All right, thank you.
Now we're moving on to board member appointments. We have, 4 board members who, are up for reappointment, and we need to, a motion to accept these. It's, Kim Daler, Daryl Adams, Asha Rodriguez, and Steve Morris. And I know some of these have not been here very long, but they were filling out terms for others. So, yeah.
Move.
So we have a move and a second, from, Chip Bunwell and Cecilia Perez, and I appreciate that. All in favor?
Do we put any conditions on their participation?
No.
So we just administered the oath of office to Asha at the last board meeting, and I'm calling her a few weeks ago, like, okay, we need to reappoint you. So that's the fastest term anyone has.
That's right.
Although I would ask Cecilia Perez to make us some empanadas. Yeah, condition there. Absolutely. So, all in favor of, reappointment for these board members? Aye. And then Asha?
Aye.
And Dan, is he still with us?
No, I gotta vote for Asha? I guess so.
That was for all 4.
Oh, okay.
Yeah, all 4.
No disqualifiers then.
All right, so okay, next is announcements. I just wanted to, is there, anybody have any announcements?
I think we should mention the conversation we had yesterday, which I thought was, the more I think about it, the more powerful I think it was. It was a conversation, I'll just mention it very briefly, and please add to it. We had a conversation over at Cabarrus Center with Flywheel, and Roy Hawkins from Atrium and several other folks that was focused on establishing a entrepreneurial and innovation challenge program through the Cabarrus Center that would focus on entrepreneurial opportunities that address the social determinants of health, and that looked at those, looks at the proposals in terms of the impact on the social determinants of health, but also on such things as sustainability, impact on the community. And I was just personally blown away by the level of energy that was expressed and some of the new ideas that I heard that came up. I can't say enough about Roy's participation in that and the fact that Atrium is coming to the table with a very strong community awareness and support.
I think what was particularly attractive to me too was not only are the projects themselves focused on social determinants of health, but they're addressing a social determinant of health because they have created the opportunity to recruit members of vulnerable and minority populations as the folks who will get funded. So the very process itself is helping advance populations who have largely been unable to get those opportunities. And so one thing that I think would be a really excellent use of some of the dollars that we may have extra from the cost settlements to help contribute to these projects, which will help generate economic development and business and projects that will look at social determinants right here in our county. Yeah, really that's right at what we're trying to do.
It will be a partnership between CHA, the center, Cabarrus Center, Atrium, and the NCRC. So in addition to everything else, it's bringing community partners together with strong voices to support these new very ventures that will come up.
That's great. Thank you. Thank you. And I did just want to mention one more time, you briefly mentioned that the State Attorney General was here to recognize the work of Russ Suda and the SUN program, as well as everyone else who's in the needle exchange program and all of our programs that are trying to reduce the impact of the opioid crisis in the county. And so that's just a super thing and really proud about that. Congratulations to you and your team. Congratulations again to Erin for her award, to all our graduates. So this has been a very celebratory and it's fantastic to be back together in the same room.
Yeah.
People's faces.
Yeah, and just a quick announcement on, good community support. We are having a community resource fair in Fred Wilson next week that is super supported by CHA, Oquendipano, Canapolis School. So it's going to be great, like 20 community partners. We are back on the ground finally. So that's going to be great.
Yeah, just great. So thanks everyone. Any other announcements or anything? If so, I'd like a motion to adjourn.
So moved.
Steve Morris, second.
Second.
All in favor? Asha and Dan?
Aye.
Aye.
We're good. Thank you so much. I'll read June 14th.
I do want to point out that I know this took long tonight,